combat experiences, suffer from post-traumatic stress or TBI. But PTSD and TBI are not limited to combat injuries. PTSD can arise from any traumatic event, such as sexual assault. We expect the Department to treat all those suffering from PTSD and TBI equally, providing the best appropriate care for each. For more than a decade, Congress has provided funding and legislative direction for the Department's PTSD and TBI research and clinical approaches. In fact, relevant provisions of law are found in each of the last 4 NDAAs. Today, our intent is to review our progress and determine where we need to go from here. Our witnesses are experts in the fields of mental health, and I look forward to hearing their views of our clinical and research progress. If they have any suggestions for the subcommittee, I welcome them. Before I introduce the witnesses, I'd like to turn to Ranking Member Spear for any opening comments she would like to make.
Thank you, Mr. Chairman. Let me join you in welcoming our witnesses here today. As post-traumatic stress disorder and traumatic brain injury began to emerge as prominent injuries from the conflict in Afghanistan and Iraq, and stories of service members facing difficulty in obtaining appropriate care became more frequent, Congress began to push the Department of Defense to be more and more proactive and increased resources for mental health prevention, treatment, and research. Since 2004, when Congress first directed the Secretary of Defense to conduct a study of the mental health services available to service members at the time, Congress has provided more than $1.5 billion in funding for PTSD and TBI-related research. Of this, more than $800 million has gone to over 400 research projects related to psychological health of service members, including PTSD, suicide prevention, military substance abuse, resilience, prevention of violence within the military, and family-related research. We need to better understand how that money has been used, what, if any, results have come from that research, where are there potential breakthroughs, and what areas may not be as productive, what gaps may exist that should be addressed, and how should we begin to prioritize the demands that continue to grow in this area. One area I believe requires more focus is the relationship between TBI and the development of chronic traumatic encephalopathy, an issue that has been getting a lot of attention, in particular because of professional football. I look forward to hearing how the Department is taking a leadership role in researching this connection. Just as important as research is the care and treatment of service members. We continually hear about access challenges and the lack of available care providers. A huge concern to me is the stigma that persists among service members that leads to them not seeking care in the first place. As we heard at the subcommittee hearing on review board agencies earlier this year, this stigma can lead not just to long-term mental and physical health problems, but also employment or financial difficulties, as discharge status may not take into account a service member's PTSD or TBI history, even with liberal consideration guidance. I'd like to learn more about what the services are doing to address these challenges, and I look forward to hearing your testimony today. Thank you, Mr. Chairman.
Thank you, Ms. Spear. Unanimous consent that non-subcommittee members be allowed to participate in today's hearing. After all subcommittee members have had an opportunity to ask questions, is there objection? Seeing none, without objection, non-subcommittee members will be recognized at the appropriate time for 5 minutes. We will give each witness the opportunity to present testimony, and each member will have an opportunity to question the witnesses for 5 minutes. We would also respectfully remind the witnesses to summarize to the greatest extent possible the high points of your written testimony in 5 minutes or less. Your written comments and statements will be made part of the hearing record. Let me welcome our panel. Our witnesses are mental health experts for the Department of Defense and the military services, and are intimately involved in these issues across their respective organizations and the Department of Defense. They are Captain Mike Colston, United States Navy, Director Defense Center for Excellence for Psychological Health and Traumatic Brain Injury, Colonel Stephen Pflanz, United States Air Force, Deputy Director of Psychological Health, Office of the Air Force Surgeon General, Lieutenant Colonel Chris Ivany, United States Army, Chief Behavioral Health Division, Office of the Army Surgeon General, Captain Thomas Johnson, United States Navy, Site Director, Intrepid Spirit Concussion Recovery Center, Camp Lejeune, North Carolina. With that, Captain Colston, you are recognized for 5 minutes.
Chairman Kaufman, Ranking Member Spear, members of the subcommittee, thank you for your support of our nation's service members, veterans, and their families. I'm pleased to share DoD's efforts in research and program assessment for PTSD, TBI, and related conditions. Last year, about a quarter of service members were seen for PTSD, TBI, or a mental health condition. Allow me to describe our progress. First and foremost, we made PTSD and TBI leadership issues with an emphasis on prevention. PTSD incidents decreased from 17,000 to 14,000 from 2012 to 2015, and TBI incidents decreased from 31,000 to 23,000 over the period. With regard to mental health across the board, we expanded access to care by tripling our mental health infrastructure since 2001. A recent RAND study validated DoD's progress, finding that DoD outperforms civilian health systems in outpatient follow-up after psychiatric inpatient care for PTSD or depression. One of our largest tasks is better understanding why PTSD and TBI often present with depression, chronic pain, substance use disorders, and suicide risk. Longitudinal research efforts, such as the 15-year study on TBI, aid our understanding and provide a framework for creating effective rehabilitation and support programs. Advances from medical research accrue slowly in PTSD and TBI. On balance, it takes 15 years or more to take a medical discovery into clinical practice. Fortunately, with Congress's support, my office, the Defense Centers of Excellence for Psychological Health and TBI, has developed a knowledge translation process for use in DoD. This capacity gives us a pathway for advances in PTSD and TBI and comorbid conditions so that we can get them to clinics quickly and cost effectively. I'd like to touch upon program assessment. We've evaluated over 150 mental health, TBI, substance use, and suicide prevention programs over the last 5 fiscal years. This program evaluation has been invaluable. Publication of this 5-year study will be completed later this fiscal year and will help us progress on the vital work of ensuring our funding is tied to programs that work, such as the U.S. Army's Embedded Behavioral Health Program and its associated behavioral health data portal. I'd like to briefly discuss a public health success in DoD that no doubt accrued from our increase in infrastructure, from which we might draw lessons for our nation in addressing a disturbing national trend. In 2015, there were over 52,000 overdose deaths in America. Opiate overdose deaths rate went up to 10.4 per 100,000 in 2015. The DoD rate was 2.7 per 100,000, about 1/4 of that. How was this accomplished? In short, through leaders' focus on the well-being of service members and a focused, outcome-based effort on prevention. Primary prevention, selected prevention, and indicated prevention, drug testing, provider training, pharmacy protections, and medication therapies. We hope to generalize some of the successes we've seen in PTSD and TBI incidents and opiate overdose deaths into other public health areas, such as suicide prevention and alcohol use disorders. With your continued support, I'm confident that our research discoveries, clinical innovations, and relentless focus on readiness for PTSD and TBI will bear fruit in the years ahead. I look forward to answering your questions.
Colonel Pflanz, you are now recognized for 5 minutes.
Chairman Kaufman, Ranking Member Spear, distinguished members of the committee, thank you for the opportunity to speak to you today about post-traumatic stress disorder and traumatic brain injury in the military and the ongoing leadership you have provided to the services regarding military mental health. The last decade has seen powerful advances in our understanding of evidence-based treatments for PTSD and TBI. I vividly recall standing outside the Air National Guard headquarters building in Cheyenne, Wyoming on a crisp autumn evening in the fall of 2010. I had just completed my training in prolonged exposure therapy for PTSD. Thrilled with the excitement about the promise of this treatment, I literally said to myself in the parking lot, I feel like I've been given the cure to cancer. Growing up, there was no higher aspiration for medicine than that. That sentiment was not entirely hyperbole. Research has proven the tremendous efficacy of these therapies. Roughly 1 year later in Afghanistan, I had the opportunity to serve combat warriors coming off the battlefield. There, I understood the importance of having real answers for difficult problems, of greeting elite professionals with elite care. I've repeated this story many times over the years because it is so important to have effective therapies to offer our patients who have given so much in the service of our country. Today, all Air Force mental health providers routinely receive training in one or more of the several evidence-based therapies for PTSD, and all airmen can be confident that they will receive state-of-the-art treatment when they enter an Air Force mental health clinic. Fortunately, PTSD and TBI rates remain low amongst airmen. Even so, we are excited about the successful translation of research into clinical practice, including requiring evidence-based therapies for PTSD, event-driven protocols for recognizing TBI, and in the use of progressive return to activity in the management of concussion, integrating behavioral health care into primary care clinics, embedding mental health professionals into operational units within highly stressed career fields, and comprehensive screening for PTSD and TBI following deployments, and throughout an airman's career are 3 additional developments that help us successfully identify and manage these conditions. On the horizon, the Invisible Wounds Clinic being established at Eglin Air Force Base in 2018 will be a powerful enhancement of our treatments for PTSD and TBI, both as a referral center and as a projection of treatment and expertise Air Force-wide. Likewise, research partners are helping us evaluate options to repackage the essential elements of evidence-based therapies for PTSD to fit existing delivery systems without losing efficacy. These emerging opportunities are every bit as exciting as the research already translated into practice. To be certain, there is much work still to be done. The Air Force partners with its fellow services and civilian academic institutions to constantly push the envelope of science so that our treatment techniques and systems of delivery grow ever more efficacious. At the same time, we are studying our systems of care to close gaps in services. Currently, a multidisciplinary task force is identifying and resolving gaps in the continuum of care and the integrated delivery evaluation system for airmen suffering from invisible wounds, with work underway on 27 specific solutions ranging from education and training to culture and policy. These solutions will translate directly into improvements in services for these airmen. I wish to thank the community for its interest in this topic and for your dedicated support of the men and women in the armed services. I'm grateful for the opportunity to appear before you on this matter of importance.
Lieutenant Colonel Ivany, you're recognized for 5 minutes.
Chairman Kaufman, Ranking Member Speer, and distinguished members of the subcommittee. Thank you for this opportunity to provide the Army perspective on providing behavioral health and traumatic brain injury care to our soldiers and their families. Healthcare is essential to readiness, which is the Army's #1 priority. I know of no area of healthcare that has faced as many challenges, made as many changes, and has achieved as many advancements as an Army behavioral health care. Over the course of my career, I have personally witnessed the impact of behavioral health support for soldiers in countless situations, from small outposts across Baghdad to clinics and hospitals across this country. Army physicians, psychologists, clinical social workers, nurses, and technicians have helped soldiers deal with the consequences of combat. Just as importantly, I've seen healthcare providers supporting the families of those that have volunteered to serve this country, as Army spouses and children also confront and overcome mental illness. The history of Army behavioral health care has included many challenges. Early in the wars in Iraq and Afghanistan, the Army realized that the size and the organization of its behavioral health force was insufficient to meet the needs of our beneficiaries. In response, it greatly increased resources and expanded the number of clinical programs to serve this population. Senior Army medical leaders also made a pivotal decision to centralize the oversight and direction of all clinical programs and constructed a small team of professionals within the Office of the Surgeon General to do so. That team set out to analyze the effectiveness of all clinical programs, identify the best practices, and replicate them across the force. Out of this process came many programs like embedded behavioral health, which has reduced many barriers to care for soldiers in combat units and improved access and readiness. The embedded model places professionals in small clinics in close proximity to where soldiers live and work. Today, over 450 providers in 62 embedded behavioral health teams support every operational unit in the Army. Data has clearly shown that soldiers are receiving care earlier and needing less hospitalization to receive treatment. Other innovations were drawn from the civilian sector. For example, school behavioral health had shown clear promise in several school districts across the country. The Army embraced this approach and placed providers directly in schools on Army posts all over the world. Children in 60 schools on Army installations can now see a provider by simply walking down the hall from their classroom. In traumatic brain injury care, in partnership with the DoD and other services, the Army has implemented a clear set of clinical standards and delivers them in interdisciplinary clinics across the force. Clinicians have reduced unnecessary variance, a key step in improving quality of care. Simultaneously, the Army Medical Research and Material Command is advancing the state of the science through a gap-driven research portfolio. Finally, the Army recognized the need to accurately understand the true effect of each patient's treatment. It developed an automated process to measure from the patient's perspective how symptoms responded to the care. The Behavioral Health Data Portal is now in use in every Army behavioral health clinic and has been used over 2 million times. To my knowledge, it is the most widely used clinical outcome system for mental health care in the country. Soldiers with behavioral health conditions get better faster because of this technology. This transformation has been possible because the Department of Defense delivers the vast majority of the care for our soldiers with mental health conditions and a history of TBI. The civilian sector could not have adapted as rapidly or as completely to meet the challenges faced by soldiers and their families. As the military health system evolves to best care for its beneficiaries, it is vital that we continue to deliver the large majority of mental health care. While much has been done, many challenges still remain. Like the rest of the nation, we continue to fight against stigma to seeking mental health care. We search for better ways to keep more soldiers engaged in care until they achieve a full clinical response. And we strive to find new technologies to assist our clinicians in delivering cutting-edge treatments. I'm committed to ensuring we overcome these and other challenges to improve the health and readiness of the force. I look forward to working with Congress in this endeavor. I want to thank my partners in the DoD, my colleagues here on this panel, and you for your continued support. Thank you.
Captain Johnson, you're now recognized for 5 minutes.
Chairman Kaufman, Ranking Member Speer, distinguished members of the subcommittee, thank you for providing me with the opportunity to share my perspectives as the director of the Intrepid Spirit Concussion Recovery Clinic at Naval Hospital Camp Lejeune. Marine Corps Base Camp Lejeune and the surrounding area are home to approximately 50,000 warfighters and their families. Traumatic brain injury, or TBI, has been described as the signature injury of the wars of Afghanistan and Iraq. Approximately 80% of all TBIs are classified as mild. Individuals who have sustained a mild TBI may only experience subtle changes in mood, memory, sleep, and balance. They have no visible signs of their injury, but are often struggling to function at work, at home, and in the community. I remember vividly when I met with a Marine sergeant and his wife in the clinic. I asked him about his medical issues. He told me that all he wanted me to do was fix his headaches so he could get back to his unit and deploy back to Iraq. I then asked his wife, what was bothering you? And there was this dramatic pause, and she burst into tears. And she told me that she felt that she hardly knew her husband since he had returned back from his last deployment in which he had sustained a TBI. Tragically, the war does not end for those families when the service member comes home. It goes on and on every day as they struggle heroically to overcome the trauma of war. The reality is that there is currently no diagnostic tool that is sensitive and specific for mild TBI. However, we have worked to overcome this by developing a holistic, integrated, interdisciplinary treatment model that employs a standard evaluation that includes physical, psychological, and spiritual dimensions. We then use this information to diagnose and treat each of our patients. We treat these service members like warrior athletes and employ both traditional therapies as well as complementary and integrative medicine to return them to the highest level of function possible after their injuries. We use a minimal amount of medication almost no narcotics, and over 90% of them returned to full duty upon completing our program. The great sacrifices made by warfighters and their families compel us to do everything in our power to support them on their road to recovery. Research in the prevention, diagnosis, and treatment of TBI is one way to fulfill this great obligation. The military health system, in partnership with civilian academic institutions, has a robust research portfolio to address gaps in knowledge and improve care for service members with TBI. For example, we have developed a progressive return to activity protocol that gives providers guidelines on how to gradually increase activity in individuals in a way that maximizes recovery. We are committed to caring for people like the retired, combat-decorated Master Chief Petty Officer who was a patient at Intrepid Spirit. He had been exposed to literally hundreds, if not thousands, of blasts during his career. After he retired, he noticed an insidious decline in his cognitive function to the point where remembering where he was going when driving, and then even driving itself, became difficult for him. After an extensive workup in our clinic, it became apparent that he had a brain injury. To this point, the DoD has an ongoing longitudinal study on traumatic brain injury incurred by members of the armed forces in order to better understand what happens to individuals like the Master Chief so they get the treatment they need. Because Intrepid Spirit Camp Lejeune is located where the service members live and work, we are uniquely suited to support these important efforts. Every day, as we work with service members, sailors, Marines, soldiers, airmen, and Coast Guardsmen who have sustained a TBI, we are reminded of the urgency and importance of our mission. On behalf of the staff at Naval Hospital Camp Lejeune and service members like the Marine Sergeant and the Master Chief that I mentioned earlier, we are grateful to the committee for your strong support. Navy medicine is privileged to work hard at something that is so important and so rewarding. I look forward to your questions.
Thank you, Captain Johnson. Captain Colston, I think you mentioned, you had mentioned that on TBI, on numbers, that you, I think that you dropped from 31,000 to 23,000. In what period of time was that? I'm sorry.
Between 2012 to 2015.
Okay. And so I suspect that this was enhanced safety because, I mean, TBI is produced by trauma. So how would you?
I think a couple things. I think the op tempo was pretty similar over those periods. So I know that there's a lot of leader intervention in regard to that thing, in regard to TBI, and in regard to efforts that leaders make to tell people not to get TBIs, safety, other issues along those lines. As you know, sir, there are very few TBIs on the battlefield right now,
Sure.
Something on the order of about 200. MVAs, sports accidents, and the like are where we're getting a lot of those, and prevention measures can be used in that regard.
Okay, thank you. So I want a question for all of you, each one of you individually. So I have a concern in that a soldier, Marine, airman, or sailor might be reluctant on active duty to go see a mental health professional or go see a neurologist about the consequences of a TBI for fear of what that may do to their career. And so, and I was a junior officer during peacetime, but I can remember deploying as a rifle platoon commander in the Marine Corps and then coming back. And if I look at the Marines, particularly during the height of Iraq and Afghanistan, that person in that same position that would have been in combat, coming back and then saying, as a first lieutenant then, saying, oh, I want to see a mental health professional. I'm concerned about post-traumatic stress and what the reaction for that command would have been. Wouldn't have been positive. And so I want you to, and I was aboard a ship not that long ago, an aircraft carrier in the Persian Gulf, and ran into the chaplain, and the chaplain was informing me, the ship's chaplain, that he would see a lot of the sailors. They would prefer to see him versus see a mental health professional because there was no entry in their healthcare books, in their health record books. And so if each one of you can comment to me how significant this issue is today and what your branch of service is doing in response to it, to gain access for these military personnel. Captain Colston.
Yes, sir. Stigma is a huge issue. We suspect that perhaps even half of people who have a condition don't come see us because of stigma. Some of it has to do with security background questionnaires, and certainly we've worked over the last number of years to allay that concern in folks. One of the things that I remember from when I deployed as an Army psychiatrist was you got to work with the chaplains. In essence, there needs to be a close relationship in a deployed setting between mental health providers and chaplains. There's a presumption of non-disclosure in mental health. I would never, as a mental health provider, run to a commanding officer with things that don't have to do with a soldier's readiness. I've never shared personal details about patients, recognizing that I need to make it as easy as possible. It's also DoD policy that there's a presumption of non-disclosure, and that policy speaks directly to commanding officers. It's obviously a leadership issue, and it's one that we need to address closely, and obviously GAO has looked at it over a number of years.
Colonel Pflanz.
Sir, I think all the services are moving to increasingly embed mental health resources closer to the soldiers, sailors, Marines, airmen. We're certainly doing that in the Air Force with our RPA community and our special operators, special tactics, and we're increasingly beginning to take that to maintainers and other units. This proximity breeds familiarity, and with familiarity, there's comfort. And as you get comfortable in individuals, you're willing to come and get care and get help. So the greater we bring care to them, the more likely it is we're going to break down those barriers and the reluctance to seek care.
Lieutenant Colonel Ivany.
Sir, I certainly agree with the previous two panelists here. This has been a key focus within the Army. I think we have made quite a bit of progress in this area. If you compare the number of mental health visits that were delivered in 2007 to all Army beneficiaries, it was about 900,000 at that time. Last year, 2016, we delivered 2.1 million visits to Army beneficiaries, more than double the number of people and the number of times that we had been able to see people. So I think our data shows that this issue is getting better. The core of our approach has been to move healthcare further forward to eliminate barriers to that care, and we have seen soldiers and their beneficiaries use it more frequently.
Captain Johnson.
Sir, we have changed the way we do business to meet this need. Specifically, we have provided education to service members about the signs and symptoms of TBI and PTSD, and moreover, that it's a real important issue. We have provided education to healthcare providers. We've also changed the way we do business in theater. Historically, if a service member had a problem, they may or may not go to medical. Now, it is an event-driven process. If you are in the proximity of a blast, you are to go to medical, regardless of your symptoms. And then the healthcare provider then can get history. They have more training to determine if you did indeed sustain a TBI or have PTSD or other medical issues. In addition, at Naval Hospital Camp Lejeune, through the Intrepid spirit, because of our holistic, integrated, interdisciplinary approach with a standard evaluation, individualized treatment, most of the service members return to duty, so 90% or so. So their testimony when they tell other service members that they went to the Intrepid spirit, that they had these symptoms and they got better, is very, very powerful. Okay. And I think ultimately they're our greatest advocates that says that this is a real phenomenon, it's treatable, and they should seek treatment.
Thank you, Captain Johnson. Ranking Member Spear.
Thank you, Mr. Chairman. As I mentioned in my earlier comments, I'm concerned about the relationship between TBI and CTE. There was an International State of the Science meeting in 2015 that agreed to 6 recommendations. The first of which was the creation of a coordinated brain bank and tissue repository system. So, Captain Colston, has the DoD created or coordinated for such a repository? And if so, how are service members informed about their opportunity to register and to donate?
Yes, ma'am. We called Dan Pearl at USAF a couple days ago about this matter. He's up to 51 brains in his brain tissue repository at USAF. Up at VA Boston, there are 98 brains of veterans. So we've moved up from about a dozen to 51 at USAF in a pretty short period, I think in about a year. The Center for Neuroregenerative Medicine is leading this process for DoD, and the Chronic Effects of Neurotrauma Consortium is leading it for VA, Dave Sifu down at
So how are we
Richmond, VA.
informing veterans and/or those who are discharged from the military of their availability of this repository?
Right now, it's what you have on your driver's license. I know that efforts are afoot to approach that issue. Of course, what we need is brains and histories, and getting the word out is a big part of the effort at CNRM and Sensi right now.
It sounds like we could do a better job at that than we are.
I think the brains versus pathology progress, ma'am, is something that we need to work on, and certainly I could take that for the record.
All right. I've been working on this issue from a different perspective for close to a decade, and I've become aware of a professor and Nobel Prize winner at UC San Francisco, Stanley Prusiner, who was the first to identify the tau protein, which is related to mad cow disease and as a result also related to TBIs. And he sent me this letter, which I want to read parts of it and then get your comments. Seemingly mild TBIs can initiate progressive nervous system degeneration involving aggregation of the tau protein into tangles within the frontal lobes of the brain. As many as 1 in 5 soldiers deployed in Iraq and Afghanistan were within the distance of an IED blast and suffer one or more mild concussive episodes. Drugs must be developed to treat such individuals. Combat-related TBIs exhibit disinhibited behaviors, including depression, insomnia, drug addiction, alcoholism, and suicide. These symptoms of central nervous system dysfunction are indistinguishable from those seen in CTE patients in whom modified tau proteins aggregate. Lowering the level of tau delays the onset of neurodegeneration. Large numbers of service members deployed in recent conflicts will develop CTE, which is one of the subset of conditions known broadly as post-traumatic stress disorder. Hence, the identification of such drugs is an urgent medical, societal, and national security issue. The development of such medicines and that the Congress continues to fund annual research and development in the Department of Defense budget to undertake this important work is key. So I guess my question to each of you, and I've got 1 minute and 15 seconds left, is what are we doing in terms of seeking out medicines, and to what degree do you concur with Dr. Prusiner on his conclusions?
Ma'am, I was honored to meet Dr. Prusiner in the Assistant Secretary's office. Right now, he's working on a novel drug discovery compound, looking at about 20,000 compounds that have to do with tau aggregation. As you know, he's an expert in mad cow disease. There's a question about protein scaffolding and the progress. The clinician in me says there probably is some nexus between TBI and CTE. But I also need to say, as a scientist, that that nexus is not fully established right now.
And the idea that we need a drug in order to try and address this condition in our service members?
I think Dr. Prusiner's work is high risk, high reward. If, in fact, protein scaffolding is what causes CTE, I think his work will bear great fruit. As a Nobel laureate, those are the kind of people we want on high risk, high reward projects, and I think he's the perfect person for that job.
Captain Johnson, neurologist.
Yes, Captain Johnson?
At Camp Lejeune, we're making efforts to make service members more aware of the brain bank by just having discussions with some of the medical leaders, both at MARSOC and in the MEF, the Marine Expeditionary Force, and the Special Operations Command. In addition, I personally am donating my brain to that brain bank. And again, I think that's one way to get the message out that I think it's so important that, that I want to participate in it. I also heard a story that I think merits discussion. There was a service member who donated his brain to the brain bank. And the family members said they felt that their son was still serving the country even after death by donating their brain to the brain repository. So we're doing everything we can, and we're supported 100%.
Colonel Pflanz.
You know, the Air Force is very concerned about the impact of recurrent, chronic, or severe TBI on its airmen and other servicemen and women. I agree with Dr. Colston that the research on the link between blast injuries and chronic traumatic encephalopathy is unclear, and more importantly, what do we do with it once we make that link? And so the Air Force and the other services are falling back clinically now on our DoD VA clinical practice guidelines. Those are our Bibles. You know, the latest literature as it emerges is incorporated into those clinical practice guidelines so that the physicians working in the trenches are using the best knowledge, best possible treatments.
Lieutenant Colonel Ivany.
Ma'am, the Army recognized this as a key issue and is fully supportive of all research efforts in this area. We feel, again, great motivation here. The Army is the lead service for the NCAA DoD Grand Alliance, which is a big part of the broader research assessment and following soldiers and athletes over time. And there are many other research efforts ongoing. We feel that it's very important to continue a broad research base in this area because the clear connections from TBI to CTE are not yet fully established. And so we feel it's important to keep many research options on the table so that we have the best chance of developing care.
Thank you. I yield back.
I recognize Mr. Bacon for 5 minutes, and then we will have to break or recess for 3 votes, and then we'll return to finish the hearing. Mr. Bacon.
First of all, thank you for treating our servicemen and women and taking good care of them. And I know as someone who's commanded 5 times the importance of what you're doing, because we've seen the impacts of when folks come back home. I'd like to ask you briefly, do you feel like you've been adequately resourced and funded to treat PTS and TBI? We'll start from left with Captain Colston.
Yes, sir. The Defense Centers of Excellence for Psychological Health and TBI has a $125 million annual budget. I feel that's more than sufficient to meet our need, and it's helped us to do, really, I think, what we need to do, which is translate theory into practice.
Thank you. Our 3 service reps.
Sir, so I would agree that we are adequately resourced to address these issues. The services are leading the way in the adoption of evidence-based therapies for PTSD. The Air Force is at 80% using these in treatment of PTSD, whereas many of our civilian communities are somewhere between 10 and 40%. And so certainly we're being resourced. The funding that's going to Fort Detrick and our military research is tremendous. That's helping us find the cutting-edge science to advance our treatments in the field.
Great to hear.
Sir, the Army does feel that we have good resourcing in this area. We feel that the major struggle is not in having enough resources, but in finding qualified mental health professionals across the country to come work with the Army at many bases that are in places that are not necessarily highly desirable to live. So things in the area of a stable civilian hiring environment, lack of CRs and hiring freezes and those types of things help very much with the Army to be able to use the resources that are provided to bring providers into the clinics to care for our soldiers.
Thank you. Captain Johnson.
We would ask for you to continue with your leadership, your guidance, and your commitment to helping all of us take care of the service members and their family.
Thank you. Here's another question. I know earlier it was harder to find effects of PTS. I think we're trying to be a lot more aggressive in finding it early. Do you have analysis that shows that we are seeing a lot more earlier reporting, earlier success at finding PTS when folks come back from deployment? I'll just start off again with Captain Colston.
Well, sir, I think one of the first things, the way that we approach that problem is by screening. So we do person-to-person mental health assessments within 90 days of the deployment, and then within 90 days after, 6 months to a year and a half, and 1.5 years to 2.5 years after. We are studying it right now. For instance, we're studying from the standpoint of the disability evaluation system. We're studying from the standpoint of the prevalence of the condition. But I don't have a final answer because we really don't know what the final answer is.
So I don't know that we can say that we're doing a better job of identifying it earlier, but with our serial screening, we're certainly giving airmen, soldiers, sailors, Marines an opportunity multiple opportunities to tell medical professionals that they're suffering from these symptoms. And if they're reluctant when they're first coming back from deployment because they're worried that perhaps they might be delayed, they have another opportunity 6 months later, and they have another opportunity. So this serial screening is so important in giving these airmen multiple opportunities, and that's got to give us an advantage in treating these earlier.
Thank you.
So within the Army, again, this has been a major area of focus to try to identify these conditions as early as possible. Screening is key, we feel like moving care forward has been another very important step. As I mentioned, we've seen many more soldiers, almost twice as frequently on the outpatient side, and have far fewer soldiers needing hospitalization for those same conditions. So for us, that's an indication that we're getting to see soldiers earlier in the course of the illness, prior to major crisis events, which lead to them going into the hospital and having very negative career events.
Thank you. Captain Johnson.
I can just echo what my colleagues have said. There are more robust screening tools that are in use to identify service members who have TBI or PTSD earlier. The Navy has also moved forward by embedding mental health in more forward positions. So what that does is that increases access and decreases stigma. And finally, in our clinic, because we use a holistic, interdisciplinary, integrated approach, frequently a service member may initially say they have TBI, but then as you get more history, PTSD due to whatever causes will become more apparent.
Well, thank you very much. I yield back my 13 seconds.
Thank you, Mr. Bacon. The hearing will resume following the vote series. commander was made aware of that appointment where I was leaving the company to go do something on Main side. So tell me about how that infantry rifle platoon commander who is expected to be to act appropriately in a stressful environment, in a combat environment, leading Marines in this particular instance, where that's not a stigma for that junior Marine officer to go to seek treatment. And it would be the same for a platoon commander of the United States Army Infantry or anything in combat arms. In any, a pilot, a fighter pilot, or somebody involved in a stressful situation in the United States Air Force or positions in the Navy. I mean, if someone's a SEAL team member or somebody, in any kind of a combat role, I mean, what is their access to care, and is there a stigma associated to it? And do you have any ideas where legislatively we could look at changing the administrative process in terms of how somebody's health care record is kept and how somebody, I think you mentioned privacy issues, but so let's go back now, starting with you, Captain Colston, and talk about where we are today, access today, and what can we do to improve it if, in your estimation, there needs to be something to improve access to where someone doesn't feel that there's a stigma associated with receiving care.
Yes, sir. Well, first of all, I think you hit the nail on the head. Junior officers, and I remember my time as a junior officer, there wasn't any discussion of mental illness or suicide or anything along those lines. And also the senior enlisted folks really do act as gatekeepers for health care. I mean, that's been one of the things that we've recognized over the years. So the first thing is policy. So we wrote a DoD policy 6490.04 that says it's DoD policy that mental health care is the same as a rash. Commanders need to make sure that folks view mental health care just like the sergeant coming up to you and say, hey, get that rash taken care of. Obviously, at the unit level, we need to make sure that happens, and that's where I think the embedded providers come in, the Oscar providers in the Marine Corps, the embedded behavioral health providers in the Army, the psychologists on aircraft carriers. I think that's where the role is. I think it's really down low. I think with regard to policy, I think we're there. There's been talk of making all mental health care confidential. I don't know that that necessarily best balances the interests of what we need to do as a war-fighting entity and meet the needs of our soldiers, sailors, airmen, and Marines. But it's certainly something that we've explored and something that we've looked at in research. One of my predecessors, Chuck Engel, has the view that that's where we should go. I think when we've kind of been through the SF-86 question 21 question with other agencies, DNI, those folks, I think where we're going to end up is somewhere in the middle, and I don't know what that middle is.
Don't we, in the civilian world, certainly in Colorado law, if a therapist has a patient who's a threat to his or her self or to someone else, then there's a reporting requirement for that.
Yes, sir. That's commonly known as the Tarasoff warning. I'm required as a psychiatrist, whether I'm in the military or in the civilian world where I've also practiced, I'm required to tell authorities if someone's a harm to themselves or others. There's been some thought of saying, well, that's really where we should cut it off. I think when we look at it from the security standpoint, we need to be a little bit higher in DoD, though.
Okay. Colonel Pflanz.
Sir, American culture is changing about mental health care. The military culture is certainly changing as well. The challenge we have is that perception is 9/10 of reality. You know, what airmen, soldiers, sailors, Marines believe is true mobilizes their behavior. What they see is the 1 airman in 10 that goes out with a medical evaluation board. The 9 out of 10 that come back that they saw me, they had satisfactory care, they don't raise their hand and say, you know, I had a great experience with mental health. And so it's our messaging, it's our training, you know, continually encouraging help-seeking behavior, educating airmen through suicide prevention training, resiliency training, other sorts of things, that mental health care is a good thing and doesn't have the negative outcomes sometimes, but not usually, that they perceive it to have, and then embedding mental health care closer and closer to them so that they're familiar with this, and that the false notions that they have, they'll start to learn are untrue. And so again, changing perception is the most important thing. We're moving the dial, but we're not there yet.
Do you think confidentiality, though, should we enhance confidentiality requirements for the patient?
What I've found in 22 years working with my patients is that the confidentiality dial is titrated to the right level. Most of my patients that I interact with, that I then speak to commanders, I'm an advocate for that individual. They're appreciative of that communication. And for the 95% of patients that I never speak to their commander, they're appreciative of that as well. I think changing that will impair, if we make us more confidential, it'll impair my opportunities to be that patient's advocate with the commander, to help that commander understand the mental illness, how it impacts the mission, and also help that commander understand that this airman, with treatment, is going to be a full-blown asset once we're done.
Under current regulations, do you have to receive permission from the patient, the airman being treated, to be able to discuss the issue with, say, that person's commanding officer?
I do not need the airman's permission for things that impact duty performance, safety, mission safety, those sorts of things.
Lieutenant Colonel Ivany.
Yes, sir. I think the key here is two things. One is a trusting working relationship between a small number of mental health providers and then line leaders. If line leaders trust and know and understand who it is they're going to talk to themselves or who it is they're sending their soldier to talk to, they're much more likely to use that care. If we just ask them to go up to the hospital to a nameless or faceless entity in clinic and just walk in and say, I need help, that's a much, much harder sell than us saying, look, please come down to the clinic 2 blocks down from where you work to see Dr. Johnson, who has seen all your soldiers in your unit for the past couple years and worked with you on many different issues. So if you have a trusting working relationship, it changes the thought process, because that leader doesn't have to necessarily think differently about mental health care in general. They just have to think differently about at least one mental health provider that's there to help them and their unit. So I think that's one of the keys. The second is that while we want to make sure that we offer as much confidentiality as possible, we have to balance readiness. So when we identify a readiness impairing issue, it is in the best interest of the unit, of the leader, and ultimately the soldier themselves to make sure that is known to the appropriate people so that we can form a community to help that soldier to get better or to help them take the next steps in their life.
Captain Johnson.
We have found that education of the service members as well as healthcare providers is one way to decrease stigma. In addition, when service members are referred to the Intrepid Spirit Concussion Recovery Clinic, and when they recover and when they return to full duty, that is a testimony to the fact that TBI and PTSD are real issues, and they're also treatable, and it encourages service members, it gives them hope to step forward, to seek treatment, and then return and get back into the fight.
Thank you very much. Ms. McSally, you're now recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, gentlemen, for your service and your care for our troops. I'm a big proponent of integrated medicine, and for myself, and really from a public policy point of view, and alternative options, which are sometimes challenging because they're not recognized often within the medical community. So, can you speak a little bit more about? I've talked to organizations that are involved with helping our troops. This is mostly with vets, hyperbaric oxygen therapy, or another organization in our community is involved in, taking troops with PTSD on, doing scuba related underwater therapy, or service animals, other non-traditional things. That there's, again, outside organizations that are already doing things like this. Sometimes it's tougher for a big bureaucracy to accept some of these alternative things that they say can't be proven. So just talk to me about some of the things that you might be working on or you think that may be useful. I've seen it in some of your testimony, Captain Johnson, but any other perspectives on these other treatments? Some of them, again, might maybe psychological, but also there's some physiological elements, I think, of cortisol, and I'm not a doctor, but other things related to the potential benefits for those that are suffering from PTSD and TBI.
Ma'am,
you've hit on a very important issue. Just to break down your question to the components, in regards to hyperbaric and oxygen therapy, currently the FDA has, I believe it's 13 approved indications for the use of hyperbaric oxygen in therapy. The Navy and the DoD provides clinical care for these approved uses of hyperbaric oxygen therapy. So our use of hyperbaric oxygen therapy is in alignment with the FDA and the Undersea and Hyperbaric Medical Society. Having said that, there's always more to learn, and we're certainly open to discussion to explore research and other projects that involve hyperbaric oxygen that can help service members and their families. In regards to complementary and integrative medicine, we have found at Camp Lejeune that service members are very receptive to it. They are hesitant about taking a pill. We use a lot of acupuncture, yoga, various meditation techniques, alpha stimulation, audio-visual entrainment, and various other tools. We have found that this results in a decreased need for medications, in particular narcotics. It is a central part of our treatment plan.
Are you bringing in experts from off base in order to partner with that, or are you building expertise within the service?
Both.
Okay.
For example, myself and one of my colleagues in the clinic has completed training in acupuncture, but we also have relationships through our NICO and Intrepid Spirits network to discuss the latest and newest innovations in complementary and integrative medicine.
Great, thanks. Captain Colston, did you have something to add?
Yes, ma'am. We welcome complementary and alternative medicine in DoD, and in fact, given the national opiate scourge, I think especially for pain disorders, it's important to have yoga and acupuncture and mindfulness and other therapies available for patients. And I think if I were to look at family practice docs across the board right now, lots of them are trained in battlefield acupuncture. We really are using it.
Yeah. Is there also, as you're maybe, again, this breaks up our thinking on some traditional mindsets, right? Transitioning that to the VA. Are you are we seeing partnering with the VA to make sure if you guys are all using this and it's working, as they're transitioning, they're not dealing with similar bureaucracy saying, sorry, that's not approved. We don't do that here. Or anybody else want to jump in?
I think that all the services are interested in the emerging research, and our partnership with the VA and our clinical practice guidelines is one of our great strengths. It makes us, despite our size, a very nimble organization as new research emerges, and almost all of our research projects are partnered with civilian institutions, so we have the best minds out there assisting us. But as this new research emerges, it's incorporated relatively quickly into our clinical practice guidelines. The one on PTSD is being updated as we speak, and that allows our practitioners in the field to have the cutting-edge tools to treat airmen, soldiers, sailors, Marines in those clinics with the best possible science that's emerged.
But you got to believe there's skepticism within the traditional medical community, right? On some of these things, I deal with it all the time, right? So how are you overcoming that? I don't know, Lieutenant Colonel Ivany, is that how you say it? You want to jump in?
Yes, ma'am. I think that the more that we put these alternate approaches out in clearly defined clinical practice guidelines, which is the clear state of the science that is a joint DoD VA work, then more and more people out there in each individual clinic will see that this is clearly beneficial, and this is not a competition. It is a augmentation to what they are doing to help their patients.
Great, thank you. I'm over my time. I appreciate all your work, gentlemen. Thank you. Here you go back.
Thank you, Ms. McSally. Ranking Member Spear.
Thank you. I just have a couple of quick questions. Lieutenant Colonel Ivany, you referenced in your statement that one of your biggest problems was hiring, that you have a 15% turnover rate with your specialists who provide the services. And I can see for the service member having to redevelop a relationship with yet another behavioral specialist is got to be problematic. What can we do to fix that?
Ma'am, I think the biggest thing that we can do is to make sure that the healthcare providers who have options to work with us or work elsewhere have trust that there is a stable hiring environment within the U.S. government and within the Army. so that, for instance, the recent hiring freeze, as we identify and try to bring providers on, we had to have many of those providers wait. And they weren't able to come on board to our clinics until we had worked through the steps to resolve the hiring freeze to get them through the gate. So they're hesitant. They hear about sequestration. They hear about continuing resolutions, and it makes many hesitant. So I think that is the single most important thing at the national level that would help us at the clinical level.
All right, Captain Johnson, you talked about some of those suffering from TBIs or PTSD self-medicating. I'm presuming this is alcohol and drugs unrelated to their condition. Is that right?
That's correct.
I have a lot of biotech in my district, and I was speaking to one of my CEOs just last night who said that they are close to finding a genetic marker for PTSD. Are you looking at that at all in the research that's being undertaken? And if not, why not?
Yes, ma'am. In fact, we have protocols underway right now to look at genetic loci for PTSD. I'd just say there are far more than one, and that's one of the things that we find across mental illness, across PTSD, depression, autism spectrum disorders. But we have funded research, and we are looking at that closely.
My colleague had to leave, but Congresswoman Shea Porter is from New Hampshire, where the opioid crisis has been particularly severe. And she got the impression from your testimony, and maybe it was you, Captain Colston, who talked about the success you're having. And she wants to know if there are certain procedures or policies or programs you've undertaken that has been particularly successful. Could you share them with us? And if you could do that for the record, that would be helpful.
Yes, ma'am. Well, I'd start with it's my opinion, but I think the fact that our death rate is 2.7 per 100,000 and the national death rate is 10.4 for 100,000 for opiates is obviously a significant difference between populations. Universally, we have random drug testing, which is, of course, not availed to most people. And, in regard to civil rights that you have when you are an active duty service member, there's a difference between being in the civilian and in the military. I do think secondary prevention efforts are really where we've excelled with regard to pharmacy interventions, a prescription drug tracking system, various issues with regards to sole provider programs, and then goalkeepers, to be quite honest with you, ma'am. One of the things that I do as a psychiatrist is I have a buprenorphine waiver. So I can give medication-assisted therapy for people who are addicted to opiates, give them a drug that they can't overdose on, give them the drug that they can't snort and hence die. I think that's been useful. And of course, we've put naloxone into the hands of first responders. And in New England, New Hampshire, Vermont, I know the governor in Vermont made the entire state of his governorship address one year on opiate overdose deaths. This is the single biggest public health crisis that we've faced. It's 55,000 overdose deaths a year. Car accidents, 38,000. Gun deaths, 36,000. AIDS was never this big. It's a huge issue, and frankly, it's a doctor-created problem, and it's on us to fix it.
Okay. Last question I have. To what extent are we now tracking those who've been diagnosed with TBI over the course of the rest of their lives to see what conditions they acquire that we would attribute to TBI?
So we have two studies underway. We have the 15-year longitudinal TBI study, which we're 7 years into. And I think that's going to talk an awful lot, especially about how PTSD and TBI and suicidality and chronic pain and substance use all overlap. And we'll learn a lot more about that. We also have an IMAP study. In regard to the here and now, how do we look at TBI? Well, we have a very robust surveillance network with regard to TBI, and we look at scientifically something called incidence, which is new incidence and prevalence. In other words, if people aren't recovering from TBI. Most TBI is self-limiting. Most mild TBI just gets better. Doesn't matter if you saw a doctor, doesn't matter what you do. What we need to get on top of are the chronic cases, and we need to learn about those.
So do you think the studies are going to provide you with that?
Yes, ma'am. I think longitudinal studies are really the way to go. The Framingham study, really, we learned a ton about coronary artery disease. I think the Army STAR study in regard to suicide is going to yield great benefit. I think longitudinal studies like the Millennium Cohort study, which in essence is a study that looks at what does military service do to you health-wise, I think they're all extremely important.
Great. Thank you all. Thank you, Mr. Chairman.
Thank you, Ms. Spear. I wish to thank the witnesses for their testimony this afternoon. This has been very informative. There being no further business, the subcommittee stands adjourned. Oh, thanks, Tom. What's that? Oh, yeah. Thank you. No, I think the big thing is that there really is, it sounds like there really is.